Good afternoon and welcome to this bill hearing for the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do have a lot of sponsor-only bills today, so just bear with us. Please note that food and beverages are not permitted in the gallery. You may see delegates with drinks at their desks because these meetings can run long, and we have quite a few bills today. Please make sure to turn off your phones or turn them to silent at this time. If a member is not present here, just be aware that they also have bill hearings and official meetings and are remaining informed of the proceedings. And please adhere to our committee rules of one question and one answer from the panel, not one question, one answer from each panelist. Please keep your questions shorter than the answers. Today, our bill hearings are going to go in the following order, again, subject to the availability of our sponsors. So we're going to start with Senate Bill 88, followed by 394, followed by 562, followed by 186, 773, 419, 83, 24, 119, 169, 444, 492, 18, 260, 348, and 917, again, depending upon the availability of the sponsors. Sponsors are not time limited on your testimony, but please keep it within reason. And if the bill is in the same posture as the cross file, please feel free to say that. Or if it is different, please let us know what is different from the House cross file. With that, we are going to bring up our first bill. Oh, and any witnesses on the non-sponsor only bills have 2 minutes. So with that, we will start with Senate Bill 88. This is the State Board of Examiners, Audiologists, Hearing Aid Dispensers, very long title. Senator Guile, if you want to come to the table and go ahead and begin your testimony.
Thank you very much, Madam Chair. It's such a pleasure to see you and to call you that and to be in your committee, and also delegates. For the record, Senator Dawn Guile, District 33, here to present Senate Bill 88. This bill is identical to House Bill 7, cross-filed by Delegate Zoney, which has passed the House. Just as a brief background, straightforward, board requests a bill that creates a limited license pathway for music therapists that was passed unanimously in the Senate, and I respectfully request a favorable report on Senate Bill 88.
Thank you very much for your testimony. Are there any questions on this bill from the members? Seeing none, this does conclude the bill hearing on Senate Bill 88. We will now move to Senate Bill 394. This is Public Health Expedited Partner Therapy. Senator Guile, you can begin your testimony.
Thank you very much, Madam Chair. This bill is an identical cross-file to HB 422 that Madam Chair sponsored, and it has passed the House. Bill is identical, and it passed the Senate unanimously, and I would request a favorable report.
All right, thank you for your testimony. Are there any questions on this bill from the members? Seeing none, thank you very much. That does conclude the bill hearing on 394. We will now go to Senate Bill 562. This is State Board of Pharmacy, Prescriber-Pharmacist Agreements, Treatment of Opioid Use Disorder. Senator Guile.
Thank you very much, Madam Chair. Senate Bill 562 is a bill cross-filed with Vice Chair Colson's bill, HB 838, that also passed the House. This is an identical posture. If you recall, this bill expands access to medication-assisted treatment for opioid use disorder through structured prescriber-pharmacist agreements. And I would respectfully request a favorable report on Senate Bill 562.
Thank you very much. Are there any questions on this for the sponsor? Seeing none, thank you very much for your testimony. This concludes the bill hearing on Senate Bill 562. And I will note for the public that are watching that these bills that are cross-filed and in the same posture were heavily considered by this committee. So if it seems like we're having an abbreviated process, it's because we did a lot of work on the front end. Thank you very much, Senator. We are now going to go to Senate Bill 186. This is State Board of Examiners in Optometry. This is Senator Augustine, if you want to come to the table and begin your testimony.
Thank you, Madam Chair, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 186, which is in the same posture as House Bill 380, sponsored by Delegate Johnson. I ask for a favorable report.
Thank you for your testimony. Are there any questions for this witness on this bill? Seeing none, this does conclude the bill hearing on Senate Bill 186. We will now move to Senate Bill 773. This is health occupations pharmacists vaccination orders. This is Senator Augustine. You can begin your testimony.
Thank you, Chair Bagnall, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 773, which is very similar to House Bill 1135 that was sponsored by Delegate Lopez. There are a couple of differences between the two bills. The first is that the House, the bill is in the original posture that it was submitted to both chambers. That's the Senate bill. And obviously, a couple of changes that were made by the House. One was to the addition of the intranasal administration, which does narrow the bill a bit. And then a second one, and that's done a couple of different times. Another one that I think colleagues really does narrow the bill is the parent or guardian language versus an adult caregiver language. What I will share is that my concern with this is that let's say if there was a grandparent or something like that, who would be an adult caregiver? Someone who, we could check the statutory language, but my understanding would be that they would be under the adult caregiver as we understand it in our statute. They would be allowed to do that. They live with the person, but they would not be under this language. Then it would just be a parent or a guardian, and a guardian is a legal term, very, very narrow, have to go to the court in order to do that. And so we're trying to provide access to this right here. And I just am concerned that this language narrows it down when we're trying to make sure that we have access. We got hardworking parents who are out there, and sometimes there's a grandparent or something like that who's in the house who really does have this best interest in mind. And so, and then there was another technical reporting change, which is, it was the will of this body. I would ask for a favorable report on Senate Bill 773, given the posture that we sent it over to you all.
Thank you very much for your testimony. Are there questions for this witness on this bill? And so you would like it to remain in the posture in which it crossed the street, is that correct?
Yeah, I mean, I feel like that the posture that we've sent it over to you all is really a solid posture, provides the access that really does make sense. There were some restrictions that have been put on, in all due respect, that I think that is a stronger bill in the way that it comes over to you.
Thank you very much.
Thank you.
Seeing no further questions, this does conclude the bill hearing on Senate Bill 773. We are now going to go to Senate Bill 419, Health Occupation State Board of Massage Therapy Examiners. This is Senator Simon Ayer.
Thank you, Madam Chair. Caught me by surprise. I was looking for the 87. I was listening for that one. Senator Simon Ayer on Senate Bill 419. This is the massage licensing revisions. This is identical to the chair's House Bill 42 that passed unanimously, and I ask for your favorable consideration.
Thank you very much for your testimony. Are there any other questions for this witness on this bill? Seeing none, we're now going to move to Senate Bill 83, which is Health Occupations Grounds for Discipline, Federal and Court Actions. This is Senator Simon Ayer.
Thank you, Madam Chair. Senator Brian Simon Ayer presenting Senate Bill 83, Health Discipline Board Revisions. I worked with the Department of Health and associated boards on this consensus legislation. It builds on last year's Maryland modernization of military laws to create consistent language in our laws. Initially, I had submitted or proposed this as 5 pages, but as I worked with the boards, they asked for additional, so it expanded to 11 pages to get them all consistent. And basically what it does is it includes all uniformed service branches that they can look to see if there was any discipline action done there. That's consistent with other sections in health law. It also updates outdated references where some places said Veterans Administration. Back a long time ago, they changed it to be a cabinet level. It's actually the United States Department of Veterans Affairs. And then there's some technical revisions. So basically, it's getting our laws consistent, making sure they're looking at all the discipline that's out there when they make their consideration. And with that, I would ask for your favorable consideration.
Thank you, sir. Madam Vice Chair and members of this committee, thank you for the opportunity to testify in favor of Senator Simon Ayer's bill. For the record, I'm Dave Dragics, retired Army Colonel and the Legislative Director for the Maryland Military Coalition. Coalition supports Senator Simon Ayer's bill. It increases the transparency of disciplinary actions when added to licenses associated with 12 specific Maryland boards in health occupations by requiring the inclusion of those actions from the Uniformed Services and the U.S. Department of Veterans Affairs. This makes common sense, as disciplinary actions from military or government service should not be overlooked. State officials need to be aware of them. In addition, while a fiscal note indicates that the bill is a technical change, the significance of adding this requirement is the consistency for grounds of discipline it adds to those Maryland boards, improving the clarity of their responsibilities. We also note that SB 0083 was passed unanimously by the Senate, and for these reasons, the Maryland Military Coalition strongly supports SB 0083 and asks for a favorable report from the committee. We would like to thank Senator Simon Ayer for sponsoring this important legislation and appreciate his leadership on this issue.
Okay, thank you. I will now open it up for any questions. Are there any questions from our members? Okay, seeing none. Oh, is there one?
That was just a wave.
Oh, wave. Hello. Well, seeing none, that concludes the hearing for Senate Bill 83. Thank you so much. We will now call, let's see who's here. Okay. Is there someone here to represent SB 119? Or 24, I'm sorry. Oh, okay. 24 first, and then I'll go to you, Megan.
Good afternoon, members of the committee. Dr. Ted Dalbridge, Executive Director of MEMS, the Maryland Institute for Emergency Medical Services Systems, to introduce Senate Bill 24, which is identical to House Bill 276, which passed the House of Delegates with support from this committee. And again, it's identical. Happy to answer any questions.
Any questions? Seeing none, this is the hearing for Senate Bill 24.
Thank you.
Thank you. All right, we will now move on to Senate Bill 119. This is State Board of Environmental Health Specialists Sunset Extension.
Good afternoon, Madam Chair.
Good afternoon.
For the record, Megan Lynch, Director of Government Affairs for the Maryland Department of Health. Very briefly, Senate Bill 119 is a departmental bill that extends the termination date of the State Board of Environmental Health Specialists for 5 additional years through July 1st, 2032. There are no amendments on this bill, and we request your favorable report.
Okay, thank you so much. Are there any questions amongst the members? Okay, seeing none, this then concludes the hearing for Senate Bill 119. I see.
Thank you.
Let's see, I see Senator Lamb, you are here. This is for Senate Bill 169. Hospitals, emergency pregnancy-related medical conditions procedures. Good to see you, sir.
Good to see you. For the record, Clarence Lamb, Senator District 12, here to present Senate Bill 169 on emergency pregnancy-related medical conditions and procedures. And thank you to members of the Health Committee here. This bill is identical to House Bill 375, which was already passed this committee, as well as the full House. As a quick reminder, this bill seeks to ensure that Maryland patients are able to access medically necessary emergency abortion care regardless of where an ambulance takes them during a serious medical emergency or crisis. This bill has passed the Senate in a bipartisan vote and would respectfully ask for a favorable committee report on this bill as well.
Okay, are there any questions? Okay, seeing none, this concludes the hearing for Senate Bill 169. All right, Senator Mounts, I see you. This is for the hearing for SB 917. Trying to find it here. Health occupations practice of audiology definition. Good to see you, Senator.
Good to see you, Madam Chair and Vice Chair, distinguished committee members. It's an honor today to be able to present Senate Bill 917. This bill proposes two minor changes to legislation that was passed 2 years ago regarding the definition of the practice of audiology. Both changes are simply clarify that health screenings as well as imaging and scanning are related to auditory and vestibular conditions of the ear. It's very simple. I would like to direct your attention to a letter that's in the file submitted by the Attorney General addressing that definition for the practice of audiology. If you look on the first page, paragraph 1, last sentence, it clearly outlines what this legislation would do. I'd ask for your favorable report. And Senator Lamb has stuck around. He is our Senate doctor representative. If we have any particular questions, he's also offered to help me out with this if we get into any of the weeds.
Okay. All right, I'll open it up for any questions. I see Delegate Kaufman.
Senator, what's the rationale for this bill and restricting the practice?
Absolutely. So the way the definition was before, it would have allowed audiologists to conduct health screenings, and this just clarifies what those health screenings are, what they're limited to. The Attorney General's letter encompasses only those health screenings related to the evaluation, diagnosis, management, and treatment of auditory or vestibular conditions in the human ear, or screenings related to prescribing, ordering, selling, dispensing, or externally fitting hearing aids or sound processors for cochlear implants. This is where I need Senator Lamb's help. Osseointegrated devices. I'll stop there. It's on page 1 of the Attorney General's letter, first paragraph, last sentence.
May I have a brief follow-up? Yes, please. What is the downside to having audiologists perform the broader checks?
The potential there is that the audiologists will be doing health screenings that are beyond those limitations which are outlined by the Attorney General.
Thank you, Madam Chair.
Delegate Szeliga.
Thank you. Good to see you. There's quite a bit of opposition testimony. Did you rectify that, or are they still opposed?
They're still opposed.
Thank you.
Okay, thank you. Delegate Martinez.
Thank you, Madam Chair. Senator, what problem is this bill aiming to fix?
The definition of the practice of audiology. So if you're having health screenings done by audiologists, the audiologist ought to be doing a health screening that is limited to what is defined, what that health screening should be, which is on page 1, paragraph 1, the last sentence, prescribed by the Attorney General.
May I have a follow-up?
Yes, please, go ahead.
Are you familiar with the scope of practice for audiologists within our VA system, for example?
I am not. However, I'd like to use one of my, do we get lifelines? Do you do lifelines? I'd like to use a lifeline, Madam Chair.
Oh, I'll go ahead and permit that if Senator Lamb wants to approach the dais.
Sure. Happy to help. So a couple years ago, a bill was passed to really expand the scope that audiologists could practice. In the governor's signing of that bill, he actually requested that there be some clarification to that. And this is a result of that, to try to clarify some of the administration's concerns with that bill that was passed, to, as Senator Mounts has said, to make sure that audiologists are not further exceeding their ability to be able to be able to do these health screenings. So it's really just kind of clarifying language to that.
Okay.
And last question. Since the scope of practice has been expanded, have there been complaints, harm caused, issues in the community that would, I guess, allow for the governor's claims in his letter to be prudent or true?
I mean, I'm not aware of any specific cases, but this is obviously just trying to clarify that scope.
Okay. Delegate Ross.
I'm sorry, I actually forgot I had a question. Thank you. Thank you, Madam Chair. So you talked about, and Delegate Zalega hinted to this too, there is a lot of opposition to the bill, and ASHA is opposing it. They are a very reputable organization. But it seems like most of it's on the grounds of access. So can you just speak to that? It sounds like you're conceding a little bit. There may be, sorry, I have a cold. I hope you can hear me well. Sounds like there may be some limitation to the access, but it's balanced with maybe safety because you want to keep the audiologist within their scope. Can you just speak to that?
Well, yeah, I think scope of practice, anytime you open up that concept of scope of practice, you've got two sides. And this is no different than 2 years ago when the original legislation was passed. You know, there'll be opposition and there'll be proponents. As far as coming down and as far as negotiating something out of this language, I believe the proponents, Med-Chi, would say absolutely not. This is by law, this is what should be in law. And not only do we feel that way, but the Attorney General has said this. And in order to implement good policy, it's incumbent to make sure that that definition is clarified. It's a very small bill, but there definitely is a lot of discussion about it.
Thank you, Madam Chair.
Thank you, Madam Chair. And with this bill, the language in this bill, do you feel that it puts guardrails to make sure they're only operating within their scope of practice?
Yes.
Okay,
yes.
thank you. Thank you, Madam Chair.
Thank you, Madam Chair. Senator, thank you for not asking your state delegate to cross-file this with you. I appreciate it.
I can't hear you. What did you say? What was that? My delegate's talking. I can't hear you. I need to get checked.
I said, thank you for not asking your state delegate to cross-file this with you.
Isn't that
Always
so?
looking out for you.
Okay, all right. Oh, Delegate Rosenberg, yes.
What are those safeguards in response to the earlier question?
So we checked with, I don't have that handy. I can get this for you, but we checked to make sure that the activities, the practices of audiology would still be reimbursable. That was one of the concerns. If you change the definition, then audiologists would not be able to be compensated. In checking both with insurers and using this information from the Attorney General's office, that we were able to verify that they would be able to be compensated. So there wouldn't be any problems there. Which is really, when you get to the root of this, that's where a lot of the consternation is created, I feel.
I think the other safeguards are that for certain conditions, I think there's concern that when it comes to ENTs, for example, their level of training is obviously to a much more deeper level of expertise, and there may be certain conditions that, while on the face of it are really, affecting someone's ability to hear, if you have some more experience from, for example, an ENT being able to diagnose that more deeply, they may be able to find that it's a more serious condition that wouldn't ordinarily just be picked up on, oh, I'm doing an audiogram, testing your hearing, looks like it's less on this one side. If you just stop there, you may be missing a condition that may be more serious.
Thank you.
Okay. Are there any further questions of the bill sponsor? Oh, Delegate Taveras.
Thank you.
Bless you.
I'm just also curious, is there an issue with regard to the lack of clarity in the definition that is lending itself not to have insurance not properly reimburse the people conducting these exams?
So we believe that it's not necessarily an issue of reimbursement, that this is really just a safety and a guardrail issue to ensure that audiologists are not exceeding their level of training to be able to offer kind of diagnosis and treatment of particular auditory conditions. That when it comes to screening, I think there's some things that are articulated now in statute that allow them to do. But there was a concern when the governor signed the bill a couple years ago that brought up that some of this may be exceeding the comfort level of what would be safe for the general public if an individual saw an audiologist with a more serious concern. And then, as Senator Moutz had pointed out too, there's also guidance from the Attorney General that this should be clarified as well. And so this is really just kind of clarifying what audiologists can do in practice. They'd still be able to seek reimbursement for medical screenings as they have been. And when we looked at it, this is not the language that's in question is not a specific piece that would preclude them from being reimbursed from Medicare, for example, which I know has been a concern. So they should still be able to fully be reimbursed for everything that they're doing, even with this clarifying language.
Thank you. Okay, thank you. Delegate.
Yes, please.
Delegate Gazzone, please.
Thank you, Madam Chair. So I'm looking at the ASHA's letter, and they reference the narrowing of the language to seemingly specifically screenings that are related to auditory and vestibular conditions of the ear. And then they go on to say that that may eliminate their ability to do sort of routine, what I assume are routine screenings, particularly around sort of, again, health and safety. They note, for example, audiologists must report a screening measure for elder maltreatment designed to identify potential abuse or neglect. So what's the actual story there? Because you seem to indicate that that would be something they could still do.
I mean, I don't, since it's not my bill, I don't have the actual bill language in front of me, but there is, the intent of this bill is to clarify the definition of things that they could do under their scope. And the things that are being clarified are those that were brought up in the governor's letter, that are brought up in the AG's letter as well. It will still allow audiologists to do screenings, which is what they feel like is important. I think the protections in place that are proposed by this bill are really just so that they don't exceed their level of practice or training. Obviously, this is a scope issue, right? And audiologists are trained differently than ENT physicians, for example. And so when it comes to diagnosing and treating certain vestibular conditions of the ear, the language here is just intended to be clarifying in that regard.
Would you like a follow-up?
I'm struggling with intention versus what the language actually says. And is there a gap there? Or a place where we're going to get tripped up? Because the language, if you're reading it strictly, again, based on what I'm looking at from the ASHA's letter, which was dated March 23rd, indicates that it would limit the screenings to only those related to auditory, and this is in quotes, quote, related to auditory and vestibular conditions of the ear, end quote. So I don't know if that means that some of these presumably kind of routine screenings that may have been being done by audiologists, the one they particularly mentioned is about elder maltreatment designed to identify potential abuse or neglect. Is that going to be something that they're not going to be able to do based on?
No, I think they can still do that. I think they can still do that. This is really just clarifying language, and I think this actually mirrors language, now that I'm looking at it, that is similar to, I think is in place for the optometrists too. So that's where some of this language was drawn from. So, when it comes to elder abuse and senior abuse, that's in the scope of anybody that's a licensed provider here in the state of Maryland.
Yes, but I would posit that it's not specific to the ear or vestibular. So I'm being a little bit literal.
Okay.
Okay. All right, are there any further questions? Okay, hearing none, we thank you for presenting this today. We will ask Ashley Bagwell if she can come forth, and then we will follow up with the unfavorable panel.
Good to see you.
Good to see you.
Good afternoon, Madam Chair and members of the committee. I'm Ashley Bagwell, here this afternoon on behalf of the Maryland Society of Otolaryngologists in support of Senate Bill 917. Obviously, this is an issue that this committee is well aware of. I won't continue to belabor the point of the Attorney General's letter. That was one of the reasons that the specific language was added on health screenings language, is that the current interpretation by the Attorney General of this language does suggest that it is limited to the evaluation and treatment of conditions of the ear. And so this language was simply to codify that interpretation. I know that understandably there is concern, Senator Gazzone, or Delegate Gazzone, as you mentioned, related to reimbursement. There was some back and forth on the floor of the Senate, extensive back and forth on the floor of the Senate related to that, to provide some legislative intent that those screening tools, like you mentioned, are the intention was to include them in that definition in the bill as proposed. I will also speak to the other change related to imaging and screening, also limits that to auditory and vestibular conditions in the human ear. There is one other state in the country, Arkansas, which includes imaging and scanning language as well, and it includes language similar to what's being proposed here in Senate Bill 917. And with that, Madam Chair, I will urge a favorable vote.
Questions of this witness? Okay, seeing none, thank you so much. We will now call an unfavorable panel. Lee McCarthy, Melissa Segev, and Gil Jen. Okay. One of you are welcome to start.
My name is Dr. Lee McCarthy, and I am a doctor of audiology and a small business owner in St. Mary's County, and I am here in strong opposition to Senate Bill 917. The question before this committee is straightforward. Should a licensed doctoral level healthcare professional, one who has earned a clinical doctorate, completed thousands of supervised clinical hours, passed a national board examination, and holds an active Maryland state license, be authorized to conduct health screenings? The answer should be self-evident, and yet Senate Bill 917 would prohibit it. Under this bill, a volunteer at a county fair, a pharmacy clerk, or a fitness gym employee could continue providing health screenings in Maryland. A licensed doctor of audiology could not. For example, a Lions Club volunteer with no healthcare training can conduct a vision screening at our county fair, and I am not permitted to conduct that same screening. That is not regulatory refinement. It is a public health contradiction. Community access to health screenings is a vital public good. Audiology accreditation standards explicitly require training in screening tools, and our students apply them daily in supervised clinical practice. We are not seeking special treatment. We are simply asking Maryland to recognize what is plainly true, that educated, trained, and licensed audiologists are fully qualified to conduct the health screenings that our patients depend upon. I respectfully urge this committee to vote unfavorable on Senate Bill 917. The people of Maryland deserve nothing less.
Madam Chair, Vice Chair Collison, and committee members. My name is Dr. Melissa Segev, and I am a doctor of audiology and small business owner with 10 locations in the state. I strongly oppose SB 917. Let me be clear. The concern from opposition is not patient safety. This bill is about restricting patient care that is already proven to be safe and effective. In 2024, Maryland modernized audiology. Since then, audiologists have been safely conducting health screenings, ordering imaging, managing patient care. There has been no evidence of harm, not one. At the same time, the federal government requires audiologists to participate in Medicare MIPS program. We are mandated to perform and report on 10 quality measures, including screening for depression, fall risk, elder abuse, tobacco use, alcohol misuse, and high blood pressure. Only 3 of those measures are related to the auditory and vestibular condition of the human ear. So if this bill limits us screenings only related to auditory and vestibular conditions, it does not protect patients. It prevents us from complying with federal law. Audiologists are required to report on at least 6 measures. If we cannot, we face up to a 9% cut in Medicare reimbursement. For small businesses like mine, this is not a minor penalty. It is a direct threat to our ability to serve patients. This bill forces providers into an impossible position, either comply with state law or comply with federal law, but not both. And when providers are squeezed, patients lose access to care. Maryland should not be rolling back safe, modern health care or creating conflicts with federal policy. You cannot require us to meet federal standards and then pass a law that makes it illegal to do so. I urge an unfavorable report on SB 917. Thank you.
Thank you, Madam Chair. Gil Jan on behalf of the Maryland Academy of Audiology in strong opposition to this bill. I'm going to jump right to the AG letter that's referenced. First of all, the one I have was done in March of 2025. It did not include any reference to the MIPS and what would be lost by the audiology. At best, this AG letter is a jump ball. They said, in certain circumstances, a lack of an express qualification, the audiology and vestibular language, when one is used elsewhere in the statute, which it was, might indicate an intent not to limit the scope of health screenings. Go to the last sentence to prove that this is a jump ball and the AG doesn't know what they're going to do. They said, based on the lack of express limiting language, which is 917, ultimately it's up to the General Assembly if it wishes to provide any express. Guess what you guys did? 24, you rejected it. 25, this letter was presented you. You rejected the limiting language. And here's why you need to reject it this year. You just passed 771 over to the Senate that mandates health boards have to do sex trafficking education. That's a mandatory reporting requirement under state law for physical, behavioral, and emotional indicators. You're going to make them violate Maryland law, and that has nothing to do with the ear. And that's what this language would do. Additionally, there was a reference to the legislative intent. Senator West got up there and read a litany of 10 MIPS requirements and asked Senator Mounts, do you agree with that? And he said, yes, you can do tobacco, alcohol, fall screening. Well, guess what? In the AG letter, it says, the first step in determining the intent of the legislature is to examine the statutory language, give clear and unambiguous plain meaning. The plain meaning is vestibular and auditory is only to the ear. It's time we ended this vendetta of ENTs against the audiologist. They are qualified. There is no evidence of any wrongdoing in the landmark bill you passed in 2024. Thank you very much.
Are there any questions for these for this panel? Delegate Johnson.
Thank you, Madam Chair. And whoever's best to answer, is there any printed example of the health screening that you guys want to continue to administer? And can that be provided to the committee?
I'm sorry, what was in general, health screenings?
A printed example.
Any printed example of the health screening that you guys want to continue to administer?
Yes, so it's in the MIPS regulations. There's a list of health screenings, and then in our billable codes by the American Medical Association, there are health screenings that need to be done to be able to bill.
Okay, thank you.
Delegate Roth.
Thank you, Madam Chair. I think I got an answer. Just be clear. So are you saying under this bill, you would not be able to do health screenings at health fairs, in schools? I mean,
correct.
Oh my goodness. Okay, thank you. Thank you, Madam Chair.
Delegate Riley.
Thank you, Madam Chair. That kind of may have answered mine. So when we changed it in 24 and 25, we did that because of was the purpose for that is to comply with the current federal law in the states that follow federal law. So we needed to tweak that and change it so that Maryland could do those additional 6 screenings.
If I might, Delegate, we didn't change it.
Right.
The original law by Delegate Martinez and Senator Guile was to say health screenings. The governor's office, because MedChi, Dr. Lamb specifically, the bill passed 44-1 in the Senate with health screenings. The one was Senator Lamb, respectfully. So you rejected that. Other states have adopted that. What this does, it limits and will restrict the 10 federal requirements for health screening, which will then cause a 9% reduction, cause your constituents to have to pay out of pocket because they can't deal those particular health screenings. So our point is, if there isn't evidence of a problem, and you can do blood testing and everything that was testified at a Walmart or a CVS, these people, contrary to what was presented, that we don't have the qualifications, are highly qualified doctors to do this. That's my response.
And just to follow up, so how many states allow and follow the federal law?
All states.
All of them. All of them.
Okay, thank you very much.
Thank you very much. I just wanted to get one point of clarification, because I know in this committee we often say, what is the problem we're trying to solve? Is it your assertion that this bill, which I think we've seen before, but this is unsolving the problem this is an unsolution for the problem we previously solved?
Yes.
Okay. Thank you. Thank you very much. We do have a panel of virtual witnesses. Thank you very much for your testimony. So if we can bring up Jana Brown, Dr. Brianna Holton, and Stephanie Szejewski. And Ms. Brown, if you want to go ahead and unmute and begin your testimony. Janet Brown, if you want to go ahead and begin your testimony.
Yes, can you hear me okay?
Yes, we can.
Okay. Madam Chair Bagnall, Vice Chair Cullison, and committee members, I am testifying today as an individual licensed doctor of audiology in Maryland, not as a current member and chair of the Maryland Board of Examiners. Audiologists have been administering and reporting health screening to MIPS and making appropriate referrals when positive with no issues to patients since 2012. Beginning this past January 1, audiologists have been assigned new hearing aid service CPT codes for billing created by the AMA. Several of these codes require the completion of basic health screenings for billing purposes. These appropriate screenings include assessment of cognitive and communication status, visual limitations, dexterity limitations, and psychosocial factors. All are important to successful hearing aid use. These would not be required by the MAA, Medicare, and health insurers if they didn't think these screenings were able to be performed by audiologists. A review of database screening measures also shows that most have no licensure or educational requirements noted in their test materials in order to perform a specific screening measure. Imposing restrictions without evidence is careless and pointless. SB 917 is not a technical correction or clarification. It's addressing a problem that does not exist and rolls back a law that was passed 2 years ago that has done no harm to consumers and in fact prevents harm to consumers by identifying possible medical issues before they become serious. If SB 917 passes and audiologists in Maryland are not able to use these codes, we will be forced to charge your constituents out of pocket, increasing healthcare costs to the consumer. Maryland audiologists will also have the singular distinction of being the only healthcare profession in the entire nation to not be able to do the mandated health screenings. Audiologists will be forced to choose whether to break federal or state law. This puts us in an impossible situation. I ask for your unfavorable report on SB 917.
Thank you for your testimony. Dr. Holton, if you want to go ahead and unmute and begin your testimony.
Madam Chair, Madam Vice Chair, and members of the committee, my name's Dr. Brianna Bruno Holton, and I'm here in strong opposition to Senate Bill 917. I'm a licensed practicing audiologist and co-own an audiology private practice with 12 office locations, 10 in Maryland, including the Eastern Shore. Our 11 incredible doctors of audiology screen, evaluate, diagnose, manage, and treat patients of all ages. This bill will directly harm both my practice and your constituents. This is not a scope issue. It goes beyond MIPS concerns. This bill puts my providers in an impossible situation. It forces my audiologists to choose between doing what is medically right for their patients and complying with restrictive state law, putting their licenses and livelihoods at risk. But most importantly, it's about patient safety. One of our audiologists recently saw a long-time patient for a routine hearing aid check. During that visit, she noticed subtle changes, facial drooping, slurred speech, and trusted her clinical judgment enough to stop everything and perform a simple screening. It was a stroke. Because she acted immediately, that patient received treatment in time and walked away with no permanent damage. Without that screening, that outcome could have been devastating. This bill removes a critical safety net for patients. Why wouldn't we want a highly trained doctor of audiology performing a simple health screening? Maryland allows kiosks, volunteers, and non-clinical individuals to perform screenings every day, yet this bill would prevent us from doing them. Allowing audiologists to complete screenings does not introduce any more harm than a screening that an individual completes themselves at Walmart. This simply does not make sense. Thank you for your time and consideration. I ask for an unfavorable report on Senate Bill 917.
Thank you for your testimony. Stephanie Sajewski, do you want to go ahead and unmute and begin your testimony?
Thank you, Madam Chair and members of the committee. My name is Stephanie Chayeski, and I represent the Academy of Doctors of Audiology, which represents audiologists in Maryland and across the United States. On behalf of ADA, I respectfully urge you to provide an unfavorable report for Senate Bill 917. I think it's important to point out that no state in the entire country statutorily prohibits audiologists from conducting routine health screenings or limits the health screenings conducted by audiologists solely to those related to auditory and vestibular conditions. Senate Bill 917, if enacted, would make practicing audiology in Maryland extremely impractical and create serious legal exposure and regulatory conflicts for providers. 2 years ago, Delegate Martinez and the legislation that passed was designed and in fact did eliminate ambiguity about audiologists conducting health screenings. Audiologists have been conducting health screenings in Maryland for a good long time before that, without any statutory prohibitions on that. When he was pressed today, Senator Lamb led you down a path that was really designed to talk more about diagnosing and treating auditory and vestibular conditions, and when he was pressed, could not come up with an answer truly around health screenings themselves, which are designed to be pass or fail with a referral. So anything that the audiologist would be doing in that regard would be sending a patient who fails a screening to an appropriate specialist, whether it was for the audiologist to continue or for an ENT or for another provider altogether. So I think what's happened is that you're being truly misled about what this bill would do. It would actually impede patient access in a very much more significant way than even the practice of audiology prior to the advancements that were made 2 years ago. And I concur with those who have previously stated that this seems to be so impractical that it is by its nature designed to impede access to audiology care altogether. And I respectfully, again, urge you to provide Senate Bill 917 with an unfavorable report.
Are there any questions for this panel from the members? Seeing none, thank you very much for your testimony. This concludes the bill hearing on Senate Bill 917, and we're now going to move to Senate Bill 260. This is Maryland Healthcare Commission membership. This is Senator Jackson.
Good afternoon, Chair Bidle, Vice Chair Cullison, members of the House Health Committee. For the record, I'm Senator Carl Jackson here to present Senate Bill 260, Maryland Healthcare Commission membership. SB 260, as amended, is in the same posture as HB 322, which passed unanimously earlier this session by both this committee and the House. I respectfully request a favorable report.
Thank you for your testimony. Are there any questions on this bill from the members? Seeing none, thank you very much. This does conclude the bill hearing on Senate Bill 260. We're now going to move to Senate Bill 348. This is hospitals and freestanding birthing centers, high-risk pregnancies, communication after discharge. Senator Jackson, do you want to bring your witnesses to the table? You can begin your testimony.
Good afternoon, Chair. Did I say vital the first time? Oh.
In a county that has Vidal, Bagnall, and Bartlett, you are forgiven.
I'm sorry about that. Good afternoon, Chair Bagnall, Vice Chair Cullison, members of the House Health Committee. For the record, I am Senator Carl Jackson here to present Senate Bill 348, Hospitals and Freestanding Birthing Centers, High-Risk Pregnancies, Communication After Discharge. SB 348 seeks to expand the mode under current law by which hospitals and freestanding birthing centers may contact a high-risk birthing patient after being discharged. Current law states that this contact must be done with a phone call, but this bill will change that to any form of contact that the patient and hospital prefer, including text messages, MyChart messages, phone calls, etc. This patient contact is performed to evaluate the parent's status and, as necessary, provide information about any postpartum complications that might have arisen. Allowing additional modalities for this contact gives healthcare professionals more options to comply with current law and hopefully reach more patients while keeping the needs of the patient at the forefront. Under the current phone call only system, hospitals are finding that success rates and patient responses are low. For example, MedStar has reported only a 39% response rates to these calls. This means that of 1,060 calls made during birthing patients in the last 6 months at MedStar hospitals in Maryland, 644 of them were not answered. However, through their Safe Babies, Safe Moms program, in the District of Columbia, which allows for different contact methods, MedStar has seen a 67% engagement rate with texting, significantly higher than the 30% previously mentioned with only phone calls. Patients who have just returned home from the hospital, who have next day pediatric appointments, who are discharged near weekends or holidays, and who are generally acclimating to the life as a new parent seem unable or unwilling to answer the phone call so soon after discharge. Add this to the fact that, as we all know, with the large amounts of spam calls occurring, people are simply less likely to answer the phone, a phone call from a number that they are not familiar with. Expanding this modality to include additional forms of contact gives hospital and freestanding birthing centers additional options to comply with the law and to better serve their patients. Following up with high-risk patients is important. But it is only beneficial if the contact is successfully made. The low success rate of phone-only contact means that the majority of these patients are simply not receiving the follow-up that they need and that the law intends. By allowing high-risk birthing patients more flexibility in how they would like to be contacted and giving hospitals additional avenues to reach them, we can take lessons learned, incorporate them into current law, and continue the goal of furthering maternal health. After working on this bill in the Senate Finance Committee throughout session, this compromise to change modality is supported by the Maryland Hospital Association, MedStar Health, LifeBridge Health, the Johns Hopkins Health System, and ACOG, the American College of What is this word?
Obstetricians.
Obstetricians and what?
Obstetrician gynecologist.
Gynecologists. For these reasons, I respectfully request a favorable report on SB 348. Thank you.
Next. Thank you, Madam Chair, members of the committee. Natasha Mayu here on behalf of the Maryland Hospital Association in support of Senate Bill 348. Hospitals strongly support the goal of early, meaningful postpartum engagement with birthing parents at high risk. This bill does not weaken the goal, it seeks to strengthen it. It comes directly from hearing from our frontline workers, the nurses and staff who have been making these phone calls since the bill went into effect in July of 2025, and who care very deeply about making sure the goals are met and effectively achieved. We thank Senator Jackson for putting the bill forward and for listening to our workers' experience and their desires, not just to check the box, but to successfully connect with patients. Very simply, the bill allows hospitals to reach patients using the method that the patients are most likely to respond to. Frontline hospital staff consistently report that many patients do not answer the phone calls during that first 48-hour window, a time when they are recovering from childbirth, caring for a newborn, and often navigating significant physical and emotional demands. As a result, hospitals are meeting the requirement to call, but not always successfully connecting with the patient. This bill addresses that gap by allowing hospitals to contact patients through the additional modalities, such as text messages, based on the patient's preference. So it's not about lowering standards, it's about making sure the outreach actually works. As you've heard, there's evidence and hospital experience that shows patients are more likely to engage through flexible, patient-centered communication methods. This flexibility is especially important for patients with complex needs, including those with substance use disorders, where the best practices emphasize ongoing trust-based engagement, not a single phone call. At the end of the day, a required phone call that never connects does not improve outcomes, but meaningful contact in a way the patient responds to does. So this bill does keep early postpartum outreach intact. It improves patient engagement and makes the law workable in real clinical settings. And for those reasons, we urge a favorable report on Senate Bill 348.
Good afternoon, Madam Chair and committee members. Happy Maryland Day. My name is Jennifer Witten here on behalf of LifeBridge Health in strong support of Senate Bill 348. I think the senator and my colleague, Natasha from MHA, articulated our feedback on this provision. And again, we really see this as being a patient choice bill, similar to what they've expressed, and I'm sure my colleagues will share at Sinai and Carroll Hospital. We get similar feedback from our patients where they would like to choose what form of communication they would like to receive information. And so I think having that flexibility in statute allows us to use the tools and allow the patients to choose what kind of modality they'd like for us to communicate with them. I also think it's important the committee understands and appreciates too, as one of our practices, that any high-risk pregnancy that we have taken care of, the patient who will be discharged will always receive a follow-up appointment with their OB or midwife. It's part of our practice within 2 to 3 days. And so we're making sure not only are we making ourselves available and reaching out to the patient after they've been discharged, we're making sure that they've got that appointment in hand with their delivery and their OB partner so that they can follow up with them as well. So thank you for your consideration. We urge a favorable report.
Good afternoon, and thank you, Chairwoman Bagnall, Vice Chair Cullison, and members of the Health Committee for this opportunity to speak with you today. My name is Quinn Collins, and I serve as the Executive Director for Nursing Strategy and Integration at the Johns Hopkins Health System. I appreciate the committee's focus on improving maternal health outcomes, an issue that remains a top priority for our teams and our patients. Johns Hopkins supports Senate Bill 348, postpartum communication requirements, clinical evidence, SUD intent, operational impact, and statutory authority. This bill updates the requirements for hospitals to contact birthing parents with high-risk pregnancies by allowing the hospitals to contact patients using the patient's preferred methodology. Providing evidence-based comprehensive care to birthing families is central to our mission. Allowing flexibility in the method for which a patient is contacted will ease the workflow and improve patient experience. Recently, data collected in December and January, our nurses experienced a 54% success rate in reaching patients by phone on their first attempt. 15% of those parents who did answer were unable to speak because they were at the pediatrician. That leaves 39% of the calls which were successful. We will continue to collect data if and when additional modalities are permitted. Our current practice is to call all postpartum mothers within the required time window, not only the high-risk mothers, which we feel is important, yet time-consuming. Recently, during one of those routine calls to a non-high-risk mom, a nurse identified concerning symptoms consistent with preeclampsia. The patient was asked to return to triage, evaluated, and ultimately admitted. Had the mom not picked up, we may have missed this interaction. This also demonstrates the importance of contacting mothers in a way that is most efficient for them, whether it be a call, a text, or some other method. In closing, I urge a favorable report to Senate Bill 348, as it will allow for hospitals to continue this important practice of contacting postpartum women in a reasonable manner for both the patient and the hospital. Thank you for your time and your commitment to maternal health.
Thank you for your testimony. Senator Jackson, before I open it up for questions, I do have 3 other witnesses on your sponsor panel. I've got Kimberly Rootson, Laura Garifo, and Ann Banfield. I'm going to come to the table and give your testimony, and then we'll open it up for questions.
Good afternoon, Madam Chair and the members of the committee. My name is Laura Garifo, and I am serving as the System-Wide Director for Perinatal Interprofessional Education, Practice, and Professional Development. I am here today on behalf of MedStar Health to support Senate Bill 348. At its core, this bill is about making sure that we can reach patients during a very critical time. Right now, the law requires hospitals to call birthing parents within 24 to 48 hours after discharge following a high-risk pregnancy. Like my colleagues, we have chosen to call all of our postpartum patients to ensure that no one is slipping through any cracks. But in practice, we're struggling to connect. We are able to connect with about 34% of all of our postpartum discharge patients, and they're those that answer the phone. What we've learned, though, is that how we reach out matters just as much as when. When we give patients the option of how to contact them, like texting or other communication methods, we see significantly better engagement. We, over the past 5 years, have a program called Safe Babies, Safe Moms in DC, and we have seen a nearly 70% engagement rate with a text-based mode of communication with our postpartum birthing parents. That's a meaningful difference, and we are committed to scaling that program across all of our birthing hospitals within Maryland and DC. That meaningful difference really impacts that early connection that we have, and it impacts health outcomes. We have seen a decrease in our adverse outcomes with all of our patients that have very low birth weight and low birth weight patients, especially within our Black patient population. Across our system, we are working on strengthening that postpartum support, and a key part is meeting patients where they are in the mode in which they would like to communicate. Ultimately, that we want to give our patients that flexibility within our shared decision-making process. For these reasons, we respectfully urge a favorable report on Senate Bill 348. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Kimmy Routson, Assistant Vice President of Government Affairs, also for MedStar Health, here to testify in support of SB 348. I will not repeat the MedStar data you have already heard here from my colleagues. We are very grateful to the bill sponsor for his leadership on the bill, and we believe prioritizing patient choice and flexibility will allow clinicians to manage the questions and the issues of these new moms effectively and connect them with the right clinicians depending on their specific needs as communicated by the patient. The goal of this bill is not to move away from the intent of the policy. It truly is to make it work better in practice by allowing that flexibility in how we connect with these patients. And for these reasons, I urge a favorable report on SB 348.
Thank you very much for your testimony. I'm going to go ahead and open it up for questions from the members. Delegate Hutchinson.
Madam Chair, probably the bill sponsor would be appropriate to answer the question. Do you want to come back up? Text only, phone only, or is this you're calling the patient, you can't get through to the patient, and so then you just elect to use text as a methodology?
Well, I'll let the hospitals take that question because they'll be the ones implementing it.
Yeah, the goal is that we will be communicating with the patient in whatever way they prefer. So if they prefer us to call them, then we'll call them. If they prefer a message through the portal, we'll do that. If they prefer texting, we can do that. It really allows the patient to be at the center of how they want us to communicate with them.
Is that determined at discharge, though, that they say that's how I want to be communicated to, or you're attempting by phone?
Usually
and then you're not getting through, then you elect to go to text? Or do you immediately know that you need to start using text?
So if we move forward with being able to communicate with them, because we are doing this type of modality in other specialties, that process is usually during admission. We ask them, how would you like us to communicate? And during admission now, we are already talking about that they'll be receiving follow-up calls after they get discharged. So this way, it just brings the discharge education to admission.
And I guess you wouldn't be here if you weren't saying that we are getting the right information and the right communication, that it stays constantly text, or again, is it, hey, I'm texting you because I want to talk to you by phone? This may potentially say you'll never talk to somebody by phone.
Yeah, if they prefer not to, then we don't have to. It's really about them deciding how they want to communicate with us.
Excellent, thank you.
Thank you. Delegate Ross, followed by Delegate Tevet.
Thank you, Madam Chair. I had a similar set of questions, actually. I mean, so, because I could see how the engagement rate is going up. Obviously, it would. But I think the quality of that engagement is also important. Can you just clarify exactly how evaluation by text works? Like, do you get a text message with a link to a survey? Do we text back and forth? Do you say, how are you? Or can I just send you a thumbs up back and say, everything's okay? Or how does that happen over text?
You want to take that, or you want me to take that? I'm happy to take that.
We're not permitted to text, so.
Yeah, right.
It would be a
Yeah.
So, Delegate, I think, sorry, Jennifer with LifeBridge. It's a really good question. So currently, okay. So, and it's going to be a short answer. So I think it's a really good question. So currently the law for this provision does not allow us for any other modality. But what I can say for other patient populations where we've implemented similar technology, so let's say a patient says, yes, I'd like to receive a text as a follow-up. It is a provider reaching out by text to say, hey, I'm checking in with you post-discharge. Have you had any complications? Do you have any issues? If that person responds, there's some triaging. If something is concerning, then there'll be that follow-up, and then they'll make a determination. Do you need to come back into the hospital? Do you need to see your provider? I think it would work very similar to like a patient communication platform as well. And a lot of those platforms will also have like triggers in them, so that if there's like certain language that's used or thresholds, it would also raise a flag. So these are tools we've used in other settings. We've just not been able to be allowed to use them for maternal health.
And I can also share that with Safe Babies, Safe Moms, that's how the communication is. It's with a nurse navigator.
Great. Thank you.
Delegate Tevetis.
Thank you, Madam Chair. So I guess just piggybacking on the level of questioning, so if we're just trying to clarify how people are doing, what's the goal? The goal there is to assess the level of response and engagement with the hospital, because 34% seems a low. For some, it could be very good, but if you want to engage for high risk, that may be very low, which sounds like this is a very specific universe. And then for those that have low birth weight, depending on the criteria under what's happening with that individual, is it the goal to provide wraparound services for that individual?
So I'm happy to answer that one. So that is exactly what the Safe Baby, Safe Moms program does, is it provides that wraparound service with a nurse navigator that helps to access the patient with either social work, mental health counselors. There's a myriad of services that they are able to access. And part of why the low birth weight, very low birth weight, all of those complications have gone down is because of the connection with prenatal care and having that prenatal journey be a little bit more strong, and those wraparound services that have been able to be provided with the text-based communication and patients having much more access.
And just to follow up, I'm not, Madam Chair, do you recall the bill that we just passed from Delegate White Holland? Yeah, I think that would be a good fit for this too, to link. I'll make them aware once it passes. But anyway, but thank you. Thank you. Responses.
Do you want a second bite at the apple?
A quick question for Ms. Witten. And do we need this, how about my chart? Do you need this bill to be able to communicate through my chart?
Yes. Yes, actually, Delegate. So unfortunately, I think as the Senator was sharing in his testimony, the current statute specifically says call. So, and it has been shared by the state that that is the instruction that we should, that's the modality. So that's why we're here, is to be able to have some other tools that we can use, again, to connect with mothers post-discharge.
Excellent. I'm a big fan of my chart. Thank you.
Thank you.
Thank you. Thank you. Seeing no further questions, I have a couple. I will confess this bill gives me pause, given the challenges that we've had to advance maternal health. So because it's not in the bill, and I think some of our colleagues were trying to get to this, like, how are you ensuring that we are identifying their choice? In the other modalities that you spoke to, where we're asking that question, are they also high risk at the time of discharge? Is there a requirement that there be an individual behind the texting? Because as we know, we are advancing AI in a lot of these spaces, and I think there is a concern that, given that these are high-risk pregnancies, that we know that contact with a live person to answer questions and identify if there are risk factors or if we are having adverse outcomes is really essential in that first 48 hours. Can you speak to what isn't in the bill and how this would look in practice? Because I know it's the hospitals that are here at the table, but we're not necessarily hearing from the nurses and midwives. I know ACOG had wanted the amendment to take the 72 hours back to 48. So if you could speak to us about what's not in this bill and how we know there's a live person making that contact, and if this modality that's already being used in other spaces is for high-risk discharges.
Do you want me to take that? Okay. Thank you. Okay, thank you. Delegate Bagnell. Let me, Madam Chair, yeah. I can take a stab. There was a few questions there, and all very, I think, really important, valid questions. And perhaps Quinn can come up too. But I think, so for the first part is the process would be, as I think MedStar shared, is that upon admissions, you go through a pretty extensive process in doing through that admissions process. And that's where you identify what the patient's choice is in terms of communicating post-discharge. That applies to any patients that we provide services within the hospital that would have a post-discharge plan. So that would be crafted in a way where you would identify, again, choice. The second piece, I think, which is another very valid question around AI use, just make sure it's very clear that we have nurse navigators that would be responsive and would be responding to whatever forms of communication. So even now, if you're engaging, if any of you have engaged with your provider, let's say through my chart, I personally also with my providers use a texting method. I am directly engaging with a provider from that unit. So at least I can say from LifeBridge's perspective, this would be a nurse leader who's from the maternal and labor department, a nurse navigator, that would be monitoring that. We also collect data on whether or not we've contacted those individuals, what the response rates are, and the other important piece that I mentioned in my testimony is also that coordination, I think, with the provider who is not a hospital-based provider, right? Because this piece of the provision that we're speaking to is only about the hospital practice. It's not the full continuum. So I think that that's why, we need to make sure we think about that whole picture, but that's why that follow-up coordination, appointment, and communication is also just as critical.
Thank you very much. Are there any other questions from the members? Oh, Delegate Ross.
Thank you, Madam Chair. This is super quick. I just want to say that I feel like this would be great as an alternative to a phone call, because I feel like if you agree that personal touch with the patient is the safest, the best, superior way to do the evaluation, that should not be replaced by the patient's choice that day. Like, these are moms at discharge, I know I was one of them, who has a lot on their mind, they're trying to get out of there. I would imagine a near 100% of those people are gonna say whatever is least, bothersome, probably, in a lot of cases. And you don't always know what's best for you. And I feel like the medical decision or the clinician's decision is also important. If you know this evaluation is best conducted by phone, that should still be the primary way. And then all of these options, which I agree, this bill I think is necessary, should still be an option for you, but maybe secondary to that phone call, are there other methods by which we can contact you? And I think of that just for anything else, just for urgent care. I was there not too long ago. And they will tell you, you can request a virtual appointment if that's your preferred method. But for certain things, we've got to do tests, we've got to see you to make sure you're okay, that you don't need some additional tests, or they're going to prescribe an antibiotic that you may not need. So I feel like it's a balance of patient preference and the best medical decision as well. Thank you, Madam Chair.
Isn't that so? All right, seeing no further questions, thank you very much for your testimony. We do have one unfavorable. If I can bring Larry Polsky to the table, and you can go ahead and give your testimony.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Larry Polsky. I'm here in opposition to SB 348 on behalf of the Maryland Association of County Health Officers. For over 20 years, I practiced as a full-time obstetrician. During that time, I delivered babies in hospitals in Baltimore and Southern Maryland. After shifting to lead a local health department for 12 years and founding the first community-based program in Maryland dedicated to treating pregnant and postpartum women with substance use disorders, I've served on multiple state commissions and work groups aiming at improving maternal health. I want to emphasize that we have way too many maternal deaths in Maryland. Our maternal mortality rate is 10 times higher than the best performing nations around the globe, and deaths among African American women are even higher. 2 years ago, HGO voted to advance a bill to help decrease preventable deaths. The bill before you today will weaken an important component of that legislation less than 1 year after it went into effect. I treat patients in person, via telehealth, by phone call, and on occasion with text communication. Texts are perfectly appropriate for a specific problem for a patient well known to the physician or nurse. I will say unequivocally, texting is not an appropriate or safe substitute for assessing high-risk patients for potentially life-threatening situations, particularly those with mental health conditions. Watering down a newly enacted step aimed at better identifying those with high-risk early postpartum complications seems like we're throwing in the towel without real effort. If the complaint of the Maryland Hospital Association and their members is that not enough patients are being reached by phone, more reasonable solutions are: 1, notify both parents prior to discharge to expect a call in 2 days and what would be a good time to call them. 2, provide the parents with the first digits of the hospital's number so they recognize an on-caller ID. And if the hospital staff are unsuccessful in reaching a patient after 2 attempts by phone, then move to text as a better than nothing means of communication. Maryland's hospital system should be working to improve health outcomes, not looking to weaken new efforts to identify and treat women who are at the highest risk for life-threatening complications. The Maryland Association of County Health Officers asks for an unfavorable report on Senate Bill 348.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for being here. This does conclude the bill hearing on Senate Bill 348. We are now going to go to Senate Bill 444. This is Certificate of Need Intermediate Healthcare Facilities. Senator Kramer, if you want to come up and give your testimony.
Thank you and good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Ben Kramer introducing Senate Bill 444, which is the exact cross-file to House Bill 498. The Vice Chair's bill, both bills passed unanimously in the appropriate chambers. And with that, thank you, Madam Chair. And my extensive panel will be coming up behind me to help validate the assertions that I just made.
Well, thank you for your patience and thank you for your testimony. Are there any questions?
Bless their hearts.
Seeing none, thank you very much for your testimony.
Thank you, Madam Chair. You all have a great day.
You too. This concludes the bill hearing on Senate Bill 444. Do we have a representative for Senate Bill 492? All right, come on up. This is Health Occupations Massage Therapy Advertising. Senator Vital, and you can go ahead and begin your testimony.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Abigail Bento. I am the legislative aide to Chair Beidel, and I will be presenting SB 492 on her behalf, as she was not able to step out of committee. Thank you for the opportunity to present Senate Bill 492, Health Occupations Massage Therapy Advertising. SB 492 is the cross-file of HB 975, which is Delegate Gazzoni's bill, which was passed by this committee and unanimously by the House. Just as a refresher, SB 492 strengthens state standards for advertisement by licensed massage therapists and registered massage practitioners. It also clarifies that the State Board of Massage Therapy Examiners' authority to enforce those standards, and this bill aims to address sexually explicit and misleading advertising that undermines legitimate practitioners, confuses the public, and can hide prostitution and human trafficking behind the word massage. I respectfully request a favorable report and for 492 and for the cross-file HB 975.
Thank you very much for your testimony. Are there any questions for this witness from the members? Seeing none, thank you very much for your testimony.
Thank you.
This concludes the bill hearing on Senate Bill 492. We're now going to go to Senate Bill 18. This is State Board of Social Work Examiners Provisional License to Practice Social Work. This is Senator Washington. Do we have anyone here for Senate Bill 18? They're not in the same posture.
Right, right. Or, yeah.
Do you want me to explain what was different? So our council is going to explain what's different, and I think Madam Vice Chair can speak to some of the discussions.
So this was a bill, if you all recall, we adopted similar, or you adopted similar amendments to House Bill 769, which was sponsored by Delegate Woods, and the House vote on that was 117 to 15. The differences between what the House adopted and what the Senate adopted is that the Senate amendments did not allow for the provisional license to be renewed, and the House amendments said that it could be renewed for an additional term up to 24 months, so it'd be 4 years total. The Senate bill said that the supervised hours completed under a provisional license may not be counted towards the supervised experience required to qualify for a certified social worker clinical license, and the House amendment said that they could be counted. And then the reporting requirement in the bill began in 2027 in the House bill, and the Senate bill, it's beginning 2026. That was, I believe, requested by the board because they wanted a little bit more time before they started reporting. And then the content of the report in the House version had the total number of active licensees who were licensed without passing the exam and the average length of time that those folks have been practicing. So just additional content to that report. So those were the differences between the House and the Senate bills.
Vice Chair Cullison.
While we were concerned that the exam was continuing in the bill, we decided that this bill, as I spoke to this group before, gave an opportunity for folks to move, to be employed while they were waiting to take the test. And I think the question, and that's the primary difference, and we're giving them 4 years instead of just 2. I think the question for Senator Washington is, can she agree with our amendments? And because it was my understanding that she was supporting the Senate version of the bill. If I had incorrect information, that would be useful, but I don't know that she needs to explain the bill to us.
My understanding is she's already heading across the street, so we'll just take a 5-minute break to give her time to come over. Delegate Hutchinson.
Thank you, Madam Chair. So, Lindsay, so at the House version, it was 2 years and then could be renewed again for 2 years. This one's just saying it's only 2 years.
Yes, so the Senate version said it could not be renewed. The House version said it could be renewed for one more term up to 24 months.
And in the Senate, you do still have to eventually pass the test.
Yes.
Okay.
Just to be clear, just to be clear, the renewal would be contingent on the successful supervised period of training. It's not like it's an automatic renewal. So just to be clear about that. Yeah.
Like when it came out of committee, we were thinking it was 2 years, but then we read it more carefully on the floor and it was 2 years plus 2 years. And that is why some of us here voted against it on the floor, so.
This has been more focus group than the bill hearing, so.
Yes.
Are we done? We're not voting it right now, correct? Okay.
Okay, we are reconvening. Senator, thank you for making the long trek across the street.
Yes.
We hope that you are feeling okay.
Yes.
I would say to you that we have actually been discussing the bill before you arrived.
That's what I heard.
Until we got the message you were coming.
Well, I always come for my bills unless I'm told otherwise. But we were listening. I'm on a EEE, and the speaker was presenting the bill. The energy package bill, and so that's where I was engaged intently with your speaker on this important House bill.
Thank you.
Yeah.
So you are aware that the House bill and the Senate bill are not in the same posture at this point, right?
Well, maybe I'm not.
Are you? So.
Here we go. Okay.
Okay.
Sorry. For the record, Senator Mary Washington here to present Senate Bill 18. It was my understanding that it's in the same posture in which the committee has heard in past. If you could tell me how it's different, then I'm happy to hear that. But I would say that even the version that was passed by the Senate committee and was taken and passed to the floor was not, in the posture that we had negotiated. It was our understanding, specifically in working with the board very hard to accept some of their provisions, working very hard across the board, that there wouldn't be we accepted the language of provisional, which wasn't really comfortable with that, wanted it to be just a license is a license, but we accepted that. And there were a couple of features that we did not expect that there would be this additional requirement to, after a period of time. We also accepted the increase of the number of hours of supervision that was required. Did not, and was in fact surprised that it additionally included a requirement ultimately to take the exam, and didn't quite understand how that would work if someone has a license for 2 years or whatever that period is, and then require them to take an exam. What would happen if they fail that exam? So that piece of it was not something, but ultimately the committee did pass that. And that is not truly the alternative pathway that the work group contemplated and recommended. And I am disappointed that that happened. It was my understanding that this committee supported that action of adding the additional requirement to pass the license. And in that regard, again, I'm still operating under what I understood, that I believe while it's not completely what we were fighting for, that it would provide social workers to work as social workers, begin to address some of the issue, and just have faith that we would come back around and understand the impracticability of removing licenses from a licensed professional without due process or cause or something. So I'm happy to be educated as to what the current posture is.
What the subcommittee was dealing with here was the knowledge that the bill would not pass in any with any major changes to it from the Senate bill. It came over from the Senate first. But what we did in the House bill is make the provisional license not just limited to 1 2-year term, but up to, it could be renewed for a second term of 2 years to give folks 4 years to during which time, anytime during that time, they could take the exam. We also changed the language in the Senate bill to say that the supervised hours could apply to the clinical, it's the clinical social work. As it came over from the Senate, those hours did not apply. We changed it to say that they should apply. And then we also added a reporting language but the first report isn't until January of 27? December of 27. But that language that report would include the number of legacy licenses that had been conferred before the exam was required or for various circumstances, and how long those folks literally, stayed on the job as legacy licensees.
And if there were any
issues. So we felt, the subcommittee and then ultimately this committee felt like this was a path forward to make the case of how folks can function and be successful in the practice and work and be paid while they're doing that. Are you comfortable with those?
I would support those amendments, and I feel they are consistent with our intent and the intent of the, recognizing that there needed to be some negotiation, but also didn't want it to be unrealistic.
So our work will be in conference, I believe, unless we can get conforming from the Senate Finance Committee. They are aware of the amendments, and we will
do what we do.
We can have that conversation.
Yes, for certainly. So again, I appreciate this committee's hard work on this and looking to. I think it's much closer to what the work group wanted. I think it's much closer to really have an opportunity to fully understand the impacts of it and really to contemplate true alternative ways of demonstrating competence. I think that's what ultimately this is about, understanding that a single exam cannot, particularly in this context, be the only way to demonstrate competence, that people should be able to have multiple ways to do that, and in particular, given what we know about this particular exam. So with all that, I ask respectfully for a amended report of Senate Bill 18.
Thank you. Are there any questions for the sponsor, the Senate sponsor? Okay. Seeing none.
All right, thanks.
So I hope that this counted towards your physical therapy for the day.
Well, I had my physical therapy at 7:30 this morning because I didn't want to miss my hearing today. Normally I have it in the afternoon, but I rescheduled it to 7:30.
Thank you.
It definitely, this was my first going across the street with my rollator, and it worked out okay. So I appreciate you all sticking around and waiting, and look forward to the work.
Great. Thank you for your effort.
Thank you.
Just very quickly, Senator, I'm still up to Walker races if you're interested.
Okay, I'll take you up. We'll do a sine die roll down the hill.
Sounds good. Thank you very much, Senator. Thank you for making the effort. And that does conclude our bill hearings for the day. And you can take us down.